Cervicalgia or neck pain is one of the most prevalent problems along with low back pain. Correctly diagnosing cervicalgia is the foundation of effective treatment. So let's see the steps included. When taking a medical history from patient, a range of questions is asked to gather pertinent information which includes information related to quality of pain, whether it is sharp, dull, stabbing, etc. Activity that triggered it, intensity of pain through visual analog scale, with 0 being no pain and 10 being the worst pain. Location of pain, whether it is localized or does it radiate towards the shoulder, arms, or head. Information related to recent injury, complain about numbness or tingling in the arms or hand, factors that worsen or alleviate neck pain, example certain positions or certain activities, information related to any previous or current medical condition or related symptoms such as headache, dizziness, or difficulty swallowing, plus history of any chronic condition such as arthritis or degenerative disc disease that may contribute to neck pain. Symptoms can vary depending on the underlying cause and severity of the condition. Some of the common symptoms associated with cervicalgia are mild to severe neck pain, muscle spasm, stiffness in the neck, numbness or tingling sensation, reduced strength or coordination in the arms or hand, especially when associated with nerve compression, headache, which is often described as tension type headache, or dizziness. Physical examination mainly includes two major components: evaluation of posture and range of motion assessment. Cervicalgia is associated with various posture issues that contribute to its development or exacerbation, which includes forward head posture, also known as text neck, rounded shoulders, that is, shoulders roll forward and inward, causing the upper back to hunch and the chest to collapse. Thoracic kyphosis, commonly referred to as a hunchback. Patient presents with raised or shrugged shoulders, which occurs due to muscle tension or poor posture habits. Prolonged sitting with improper posture, such as slouching or leaning forward. Sleeping in positions such as sleeping on the stomach with the head turned to the side or using an unsupportive pillow can lead to neck pain. Assessing range of motion in cervicalgia patients is an essential component of the clinical examination to evaluate the extent of neck mobility and identify any restrictions or abnormalities. The key movements to assess during active range of motion include flexion, extension, lateral flexion, and rotation. Passive range of motion helps in the assessment of pain, resistance, muscle guarding, or difference between active and passive movements. Evaluation of end feel at the end range of each motion is crucial. It is described as soft, firm, or hard and provides significant insight into the integrity of the joint and surrounding tissue. Other than this, palpating the cervical spine and surrounding muscles for tenderness, swelling, or trigger points is also important. Special tests are used to narrow down potential causes behind neck pain. Sperling test is used for cervical radicular syndrome. Reproduction of symptoms such as pain or numbness present as a positive sign. Upper limb tension test. It is helpful in evaluating the mobility and irritability of neural structures, including the brachial plexus and cervical nerve root. Reproduction of symptoms present as a positive sign. A series of sequential movements are performed on the affected upper limb, including shoulder abduction, elbow extension, forearm supination, wrist and finger extension, and cervical lateral flexion and extension. Shoulder abduction test or relief sign helps in differentiation between cervical radiculopathy and shoulder pathology. Relief of radicular symptoms gives a positive sign when patient abducts his arm to 90 degrees. Distraction test when performed provides relief of symptoms associated with cervical nerve root compression. Cervical compression test is used for the assessment of facet joint pathology or nerve root compression. Reproduction of local neck pain or radicular symptoms occur when axial pressure is applied to head. Valsalva maneuver is used to assess for increased intraspinal pressure and aggravation of symptoms associated with disc herniation or spinal stenosis. Reproduction of symptoms act as a positive sign. Alar ligament stress test. It is used to assess upper cervical spine instability or injury to the alar ligament. Normally, a capsular end feel is felt. Excessive translation or rotational movement of the atlas relative to the axis gives soft end feel. Diagnostic imaging like X-ray is used to identify fractures, dislocation, degenerative changes like osteoarthritis or osteophyte formation, and alignment issues like cervical lordosis or kyphosis. CT scan gives precise information or visualization of spinal stenosis and facet joint pathology. MRI helps in identification of problems like disc herniation, spinal cord compression, nerve root impingement, spinal stenosis, ligamentous injuries, infection, and inflammatory conditions like cervical spondylosis and rheumatoid arthritis.